Okay, good evening. Thank you for joining us and welcome to our webinar this evening on behalf of the Resident and Associate Society of the American College of Surgeons. I am Allison Casey and I am the administrator at headquarters. Tonight we are being joined by Dr. Jay Lieberman, who's going to talk to us about clinical documentation and improvement. Before we get started with our webinar tonight, I'm going to tell you a little bit about Dr. Lieberman. He is a clinical assistant professor at the Lehigh Valley Health Network campus of the University of South Florida, Morsani College of Medicine in Allentown, Pennsylvania. He is a board certified in both surgical critical care and general surgery. He has also earned an MBA degree with a focus in multi-sector health management. And in addition to his clinical and educational duties at LVHN, he is actively involved in initiatives to improve documentation, coding, value analysis, supply chain, protocol development. Also named Vice Chair, Department of Surgery, Hazleton, Assistant Medical Director at Lehigh Valley Physicians Group in Hazleton. Dr. Lieberman is a fellow of the American College of Surgeons and has been for nearly 10 years. He is an active member of the ACS General Surgery Coding and Reimbursement Committee, and this committee acts in interests of general surgeons for many legislative and regulatory issues that impact coding, billing, and reimbursement for general surgical services. So we're going to be going through a slide presentation with Dr. Lieberman for the next 45 minutes, and we will take questions and answers following that time. So if you do have questions for Dr. Lieberman, please type them into the panel on the side of your screen. So Dr. Lieberman, welcome.
Hi. Before Dr. Lieberman talks, this is Becky Hoffman. Hi. Sorry, I got on 1 minute late, and I apologize. I just wanted to say just a quick thank you. My name is Becky Hoffman. I'm the secretary of the RAS, and I do want to give a special thank you, Dr. Lieberman. It's great to have you on giving us this webinar tonight, and thank you for giving your precious time to help us improve our documentation, which is, I think, a much-needed topic for us. So thank you very much. We very much look forward to it.
Well, thank you. I appreciate the invitation. And thank you to Allison for coordinating everything, and I appreciate all the effort the Resident and Associate Society and the Young Fellows have put forth. And thank you to everybody for taking some time out of their busy day to attend tonight. Next slide, please. Next slide. Allison?
Yep, I'm on documentation excellence.
Oh, mine's not moving. Let's see. Yeah, mine's not moving forward.
It's not just you, mine either. Let's try to figure it out.
I'm still on the first page, the title page. All right, now moved.
Okay.
Okay, so what are we going to talk about tonight? When I first was asked to give a presentation, I had actually suggested we talk about clinical documentation improvement and coding, and I quickly realized that to cover the basics of both those topics would go much further than our 45 minutes. So I've narrowed it down pretty much to clinical documentation improvement with a couple of slides about coding at the end. Very, very superficial. And if the need is there, maybe we can revisit that in the future. But in the meantime, tonight we're going to really focus on clinical documentation improvement. So what we want to relay to you is why is it important to make sure that your charts are appropriately documented for a variety of reasons. The most obvious being reimbursement. Appropriate documentation affects reimbursement very dramatically, and also many, many quality measures, such as length of stay, mortality, hospital readmission, transfers to higher levels of care, surgical site infections, etc. And it also affects public profiles, not only for the hospital, but for the individual provider. So the best way I thought to illustrate this was with two clinical examples. So tomorrow after the lecture, everybody's in the hospital, and at 6 a.m. the ED calls you with a 23-year-old man with a CT scan proven appendicitis with no comorbidities. You go see the young man and call the OR to book the case. And being as efficient as they always are, the OR gets you in at 8 a.m. He's asleep, and by 8:30 you're done with the case. By noon, the patient is eating Jell-O and drinking chicken broth. By 2 p.m. he's voiding and ambulating, and by 5 p.m. he's home on his couch playing video games. The following morning at 6 a.m. the ED calls you with a 63-year-old man with CT scan proven appendicitis. And you go see him and identify the fact that he not only has appendicitis, but he has end-stage renal disease. He's on home oxygen. He has uncontrolled type 2 diabetes mellitus, and he has chronic systolic congestive heart failure. And he has some vague complaints of exercise intolerance. So he's admitted to the hospital. You have a cardiology see him, you have renal see him, and you have endocrine see him. And they all say he's low risk for surgery. And by 2 p.m. he's cleared, and you call the OR, and again they efficiently get you into the OR by 4 o'clock when he's asleep. 30 minutes later, by 4:30, you're done with the case, and the anesthesiologist is a little hesitant to extubate him in the PACU because of his history of home oxygen use and congestive heart failure. So he's sent to the ICU intubated. Several hours later, the ICU surgical resident extubates the patient without a problem, but there's no beds in the med-surg unit, so he spends the night in the intensive care unit. The following morning, he needs dialysis, which he undergoes without a problem, and he, similar to the young man, ambulates in his eating and is discharged home later that night. So the differences are very dramatic when we talk about them. But if you just write on the chart that you take care of a 23-year-old man with appendicitis and a 63-year-old man with appendicitis, you can see very clearly that the 63-year-old man used a significant number of resources more than the 23-year-old man. Not only did they need cardiology, nephrology, and endocrinology consults, they needed an ICU bed overnight, they needed the dialysis unit for hours, they needed hours more nursing care, they needed EKGs and chest x-rays and more labs. So if you document only appendicitis, you're going to be spending resources on a patient but not getting reimbursed for that patient. And in theory, since that patient is sicker, there is a slightly higher mortality risk for this patient. So that's another reason why documentation is important. Next slide, please. So at our at Lehigh Valley Health Network here in Allentown, we call our initiative Documentation Excellence, and it's essentially to ensure complete and accurate documentation to reflect the true severity of illness of the patient and the expected number of resources used to take care of that patient. Essentially, you need to get credit for the care that you give. To get reimbursed at a lower rate then the resources you're using is just going to essentially, if you do it over and over again, your hospital is going to go out of business. So we want you to show the severity of illness and the risk mortality because it's critical to your outcomes, it's critical to your quality rankings, and it's critical to the reimbursement you receive. Next slide, please. So this is just another slide to illustrate what clinical documentation touches. We've talked about most of these already even. Quality in terms of risk mortality and severity of illness, reimbursement, length of stay, profiles both hospital-wide and individual physician, readmission rates, any audits you may have, and compliance. Next slide, please. So the bottom line, though, is that patient care actually is the most important reason to document accurately. You can imagine a situation where you're consulted by the hospitalist to see a patient who has septic shock secondary to perforated sigmoid diverticulitis. But if you go over to the chart and write up arrow HR and down arrow BP and down arrow UO, it's really not telling anybody how acutely ill the patient is or how much concern you have over the patient's condition. And as we mentioned earlier, documentation is very important for quality measures, both network-wide and personal, and reimbursement, again, network-wide and personal. Next slide, please. So let's kind of get into the meat and potatoes of the talk here. So the first question is, how are hospitals actually paid? So what, in general, and this is a generality, it does not exactly true for every single patient, but in general, hospitals are paid a fixed amount of money for each patient discharged based largely on the diagnosis they have. And you might have heard of a DRG, it's a diagnosis-related group. We'll get into it in a minute, but that's essentially it. You have a diagnosis, so our 23-year-old appendix patient has a DRG, and the hospital makes X number of dollars for that patient. Our 63-year-old guy, assuming appropriate documentation, has another DRG and has Y number of dollars. And it's interesting that CMS, the Center for Medicaid and Medicare Services, is very smart. They place the risk of compensation at the hospital level and not at their level. So if you don't document right, you're going to spend the resources but get paid less. So it's completely risk at hospital level. And we'll go into this a little bit more, not too much in detail, but essentially what happens is each hospital is assigned a base payment for DRG, and it's adjusted by many factors, but it's a pretty complex formula that CMS uses to generate a dollar amount that you get paid per DRG. Next slide, please. So DRGs have been around for a long time. The last change was in 2007 when CMS implemented MSDRG, which is Medicare Severity Diagnosis Related Group, and that was put into place to do better, to make sure that the DRG actually reflects the severity of the patient's illness. There's about 750 or so DRGs, so you can imagine that it's a pretty complicated system. And essentially it links the type of patient that the hospital is treating to the cost of treating that patient. And there's two components to the MSDRG system. There's a principal diagnosis and there's a secondary diagnosis. The principal diagnosis is essentially the reason the patient's admitted. For our example, it would be appendicitis. Here's just some DRGs that, just to look at as an example, appendectomy, which we've been talking about. The DRGs are 338 to 343. The knee procedures, 485 to 489, and thyroid, parathyroid, 625 to 627. So next slide, please. So along with the primary diagnosis, there's secondary diagnosis. And these diagnoses are used to illustrate more accurately how sick the patient actually is when they present to the hospital. And it also reflects an anticipated increase in resource utilization based on that sickness that the patient presents with. And you might have heard these terms before too, but we basically assign MCCs or CCs to these DRGs. An MCC is a major complication comorbidity, which defines a higher level of severity of illness. And a CC is a complication or comorbidity, which defines an intermediate level severity of illness. Next slide, please. DRGs are also able to be used to evaluate and compare quality outcomes across groups because they're clinically similar. So the DRG for the 23-year-old appendicitis contains, in theory, if you document appropriately, contains exactly the same types of patients for my hospital, for the hospital down the street, for the hospital across the state, for the hospital on the other side of the country, for any of the hospitals where you guys are tonight. So the patients in those DRGs, assuming appropriate documentation, should be similar. They reflect resource utilization for these specific clinical conditions. There's another type of DRG. It's called an all-patient refined DRG. It's not quite as wide used as the MS DRG, but it basically just more accurate in terms of severity, illness, and risk of mortality. So how does CMS actually pay you? They don't just say you get $100 for an appendix DRG. They assign each DRG a relative weight, and that weight also reflects the average amount of resources that are predicted to be utilized for a Medicare patient with that disease. So each DRG has a relative weight. Next slide, please. So the higher the relative weight that the DRG is assigned, it reflects that the patient's sicker, and it reflects that you're going to be using more resources, and it also reflects an increased reimbursement secondary to that relative weight. So the higher the acuity of the patient, the higher the relative weight. So the scale goes from 0 to 26. So essentially, to think about it very simply, if you have a relative weight of 4.0 and you have a relative weight of 2.0, the patient who has a relative weight of 4.0 necessitates a 2 times reimbursement than the patient with a relative weight of 2.0. So the CMS takes the relative weight and multiplies it by a base rate that is assigned to each individual hospital. So the reason why your base rate can change is based on a number of factors, which are some are very complicated, but some simple ones might be the proportion of indigent people in your community. The more indigent people you take care of, the higher your base rate. If you're a teaching hospital, the higher your base rate. Medical students, residents, as well as fellows would give you a higher base rate. So it's entirely possible that when I take out an appendix and when you take out an appendix, the CMS reimburses our hospital a different amount of money based on the fact that our base rates are different, even though the relative weights for the DRG are the same. Next slide, please. So here's some examples of DRGs. We talked about there being about 750 of them, and we talked about the relative weights being from 0 to 26. So as you can imagine, 26 signifying the highest acuity patient is Medicare has identified that a heart transplant with an MCC is the sickest patient in theory that a hospital can take care of. So if you, so if you have a heart transplant with an MCC, and we'll go over some examples of those in a couple of slides, then that patient would be assigned a relative weight of essentially 26. If they don't have an MCC, then they would be assigned a relative weight of 14.5. So you can see that if the patient has a MCC, but you don't document it, you have essentially, not half, but it's close to 50% less reimbursement. Even though the patient might have it, if you don't document it, you're losing half the reimbursement. Other sick patients, as you might expect, patients on ECMO, or patients that have tracheostomy with mechanical ventilation for 96 plus hours, they have a relative weight of 17.54. Next slide, please. Now you can see how quickly it drops, right? We have a major chest trauma, which 8 rib fractures on an old patient from a nursing home. This major chest trauma with an MCC, and again we'll go over some examples in a few minutes. But it's only 1.4 relative to the heart transplant, which is 26. So CMS is essentially saying probably close to 20 times more resources are being utilized for taking care of a heart transplant than an older patient with 8 rib fractures and a major comorbidity or complication. And you can see how the relative weight changes as the patient theoretically gets less sick. From you go with MCC to a CC is 1.46 to 1.0, and if the patient doesn't have either of them, it's 0.71. So the numbers on the left are the DRGs, the 3-digit numbers. So DRG 185 is major chest trauma without MCC or CC, and the relative weight is 0.71. If you have an MCC to that, the hospital gets reimbursed more than double the amount of money just because the patient came in with an MCC. And again, I'll show you some examples in a second. Just some more examples that are pertinent to surgery. Adhesiolysis, 4.1. And here's our patients from earlier in the talk. DRG 343, appendectomy uncomplicated without MCC or CC. The 23-year-old young man is a relative weight of 1.0. Now, the 63-year-old man with all the comorbidities, his DRG is 341, and his relative weight is 2.15. So if you document appropriately, if you write down everything that that older man has, the hospital is going to be reimbursed more than 2 times as much to take care of him. And it should, because he stayed in the intensive care unit. He used nursing resources much more, and he had 3 more consultations, numerous EKGs, etc. Next slide, please. So here's some medical examples of DRGs. Asthma without an MCC is 0.66. So it's 30 or 40 times higher relative weight to take care of a heart transplant than it is to take care of asthma patients. And again, that's appropriate. Acute myocardial infarction, discharged alive without an MCC or CC is 0.75. Can you go back one slide, Allison? So an MI that leaves the hospital alive is 0.75. Yet our 23-year-old kid with appendicitis who goes home is 1.0. So the hospital gets more in terms of reimbursement for taking care of a young, healthy appendectomy patient than a patient who comes in with a presentation of acute myocardial infarction without any other comorbidities and goes home alive. Next slide, please. Next slide, please. So here's some common MCCs. We've been talking about how, and if you noticed on the slides, as you add a CC or an MCC, the DRG changes. So for uncomplicated appendicitis, there's 3 DRGs. A DRG without MCCs or CCs, a DRG with a CC, and a DRG with an MCC. So here's some MCCs. Diverticulitis. These are specific, or I tried to get them specific to surgery. Diverticulitis with hemorrhage, gastritis with bleeding, malnutrition, acute pancreatitis, H-flu pneumonia, PE, end-stage renal disease, pressure ulcer, stage 3 or 4. So our 63-year-old gentleman automatically, right here with end-stage renal disease, has an MCC. So if you write on the chart, 63-year-old man with appendicitis and end-stage renal disease automatically changes their DRG to the appropriate one, and the hospital gets compensated appropriately. Next slide, please. Some more common MCCs: cardiac arrest, as you might imagine, respiratory arrest, sepsis, acute systolic and diastolic heart failure, shock, coma, DKA, encephalopathy. Next slide, please. So here's some common CCs, comorbidities or complications: chronic systolic, diastolic heart failure, shock if unspecified, ETOH withdrawal, ventilator-associated pneumonia, CKD, morbid obesity. Morbid obesity is CC. So what that's saying is that CMS identifies that patients with a BMI over 40, in general, on average, use more resources than patients with a BMI of less than 40. So if our 23-year-old kid had a BMI of 45 and he went through the hospital with the same resources utilized, the hospital would actually be compensated more because he would have a CC attached to his DRG. His DRG would be different. Malnutrition with a BMI of less than 19, paraplegia. Next slide, please. A couple more common CCs. You have acute blood loss anemia, urinary tract infection, acidosis or alkalosis, pleural effusion. We see that often on our trauma service. GI bleed, bacteremia, delirium, hyponatremia is also very common. Next slide. So another issue that is affected by how well you document is something called present on admission, or a hospital-acquired condition. So essentially, any condition that's present when you place an inpatient order is a present on admission diagnosis, and it's intended to separate those diagnoses present on admission from those acquired as an inpatient. And the reason is important because essentially, here's an example, and these dollar amounts are not accurate. They change from year to year and from hospital to hospital and state to state. So it's just a way to illustrate the change. So if you admit a patient with intracranial hemorrhage with no MCCs or CCs, the reimbursement could be $5,348. If the patient also fell and fractured their patella during the fall, and it's documented to be present on admission, the hospital reimbursed $6,177. And if the patient falls in the hospital and fractures their patella, the hospital will only get reimbursed $5,348. So the hospital doesn't get paid to take care of hospital-acquired conditions, wound infections, post-op MIs, respiratory failure post-op. The hospital doesn't get paid to do that. So if you're taking care of trauma patients and there's a fractured patella, you need to make sure that it's on the H&P so the hospital gets appropriate credit for it. Because if you look at the chart 2 days later and the lady falls and has a broken patella, you're going to have to take care of that patella and not get any extra resources, even though you're any extra reimbursement, even though you're spending more resources. Next, please. So we've been talking a lot about severity of illness, and for the intents and purposes of CMS, they define it by four levels. Minor, in terms of extent of organ system derangement or physiologic decompensation. Minor, moderate, major, or extreme. Next, please. Same with risk mortality, which provides a medical classification to estimate the likelihood of inpatient death. Minor risk, moderate risk, major risk, or extreme risk. Now, if you think about it, it's a complicated equation to come up with each, but our 23-year-old appendix versus our 63-year-old appendix probably would have a different risk of mortality. So it's important to make sure that you document right so the risk mortality is right. Next, please. So how do we all use this? What does all this stuff actually mean? And there's actually a very simple equation that hospitals use to compare themselves to others, and it's called the case mix index. And essentially what the case mix index is it reflects the diversity, the clinical complexity, and the anticipated resource utilization in the population of patients that the hospital cares for. And essentially what it does is just an average. It takes all of the relative weights of all of the patients that they care for in a unit of time and divides it by the number of discharges in that unit of time. So if you took care of only 10 heart transplants in the last month, you'd add up 26 10 times, you get 260. You divide it by the number of discharges, assuming they all left, and you'd have a case mix index of 26. If you took care of only bronchitis and you had a relative weight of 0.66, and you took care of 10 bronchitis patients and you add them up and you get 6.6 and divide by 10, you get back down to 0.66. So your case mix index would be 0.66. So just looking at the case mix index of a hospital will tell you that that hospital is taking care of sicker or less sick patients just based on what that number is. So looking at those two examples and you see a case mix index of 26, you're like, that hospital is not only taking care of sick patients, they're using a lot of resources to do it. And the hospital with a case mix index of 0.66, you look at it and say, well, their patients aren't so sick, they're not using a lot of resources. Now, these are dramatic examples because no hospital can have a case mix index of 26. There's no hospital in the world that takes care of only heart transplants with MCCs. So your case mix index is lower than 26 and higher than 0. So it's important to look at, so if you take Lehigh Valley Hospital, the hospital on that, for example, and you look at their case mix index or the case mix index of any hospital, the hospital that you're working at, if you compare it to the hospital down the street and your case mix index, for example, is 1.5, and the hospital down the street is a 200-bed critical access hospital with no real resources to be utilized, and you're a tertiary care center with a 1,000-bed hospital, and your case mix index is 1.5. If their case mix index is 1.6, you have to kind of put the light bulb on and say, wait a second, what's going on here? How could our hospital with 1,000 beds, a tertiary care center, have a case mix index of 1.5, which shows that we're taking care of patients with X number of diagnoses that are not as sick as, and we're not using as many resources as a critical care critical access hospital with just 200 beds and not a lot of resources. So that should raise some question marks. Why is your case mix index lower than a community hospital in the rural country? Now, you can't really compare your case mix index to hospitals that do things that utilize more resources than you do. So we don't do heart transplant or lung transplant or liver transplant. So it's hard for us to compare our case mix index to a institution that does those things, because automatically, just by nature, just by the fact that they're doing those cases, their case mix index is going to be, it should be anyway, it should be higher than ours. Next slide, please. So what actually affects the case mix index? And we've actually talked a little bit about some of them already. The easiest thing to identify is accuracy and specificity of documentation that you're doing. If you're not documenting, if you're documenting that you're taking care of 23-year-old patients with appendicitis, but you're actually taking care of 63-year-old patients with appendicitis, end-stage renal disease, etc., your case mix index is going to be lower, and you're actually going to be spending the resources to take care of patients that would suggest your case mix index is higher, but if your documentation is not appropriate, then your case mix index is going to be lower. So what else impacts your CMI? Medical versus surgical volume. We showed you that bronchitis is 0.66, asthma is 0.66. You have to do 30 or 40 cases to even approximate one heart transplant, but their relative weight. So the more and more heart transplants you do would impact your CMI positively, and the more and more asthma patients you take care of would lower your CMI. So medical in general not negatively impacts, but lowers your CMI, whereas surgical increases your CMI. Again, the more high-weighted cases you take care of, elevates your CMI. And like we talked about on the examples, tracheostomies and major surgeries have higher relative weights. So the more and more tracheostomies you do per month, your CMI is going to be higher. And that's why your CMI can vary per month, because you're taking care of a different, not exactly the same patient population each month. And what service lines you have, I touched on that a little bit too. Transplantation is the major service line in terms of CMI. If you do heart transplant, liver transplant, your CMI is by definition, assuming you document appropriately, by definition is going to be higher than anybody else's CMI. Cardiothoracic is another very heavily weighted relative weight service line, cardiothoracic and neurosurgery. Annually, there's updates to the DRG relative weights, which can impact your CMI, as well as coding and guideline changes. Next slide, please. So here's some consequences of poor documentation. We touched on a lot of them, but just to kind of bring it all together and summarize. Poor reimbursement, poor quality metrics in the public profiles. So, and this is an important one. Low severity of illness and low risk of mortality. So your report cards might suggest that you're providing substandard care if your mortality rate is actually higher than expected. So if you're not documenting and you have a low risk of mortality, but your patient actually is really sick and they die, your mortality rate is going to be higher than the expected mortality rate. So it's important to document appropriately. The length of stay you're allotted is actually based on documentation too. So if you document poorly, your length of stay is going to be allotted is going to be shorter. You have inaccurate coding and reimbursement secondary to that, poor legal defense, and poor cost efficiency for the physician. Next, please. So let's look at some examples. Urinary tract infection without MCC or CC is a relative weight of 0.78, a risk of mortality of 1, and a length of stay of 3.4. The hospital's reimbursed. Again, this is not accurate cost data, but it illustrates well $4,061. A urinary tract infection with an MCC is 1.21, 3 risk of mortality, length of stay of 4.8, and a reimbursement of $62.92. So you can see how just documenting an MCC not only gets the hospital $2,200 more, but it elevates the risk of mortality. And the same thing with pneumonia, as you can see here. Next slide, please. Here's another example. Say you admit a patient, an 80-year-old lady, who is, and you write unsteady gait, diarrhea, vomiting, chills, and fever. That alone assigns the patient a risk of mortality of 1. And she eventually dies in the hospital. But in reality, her blood pressure was 80/50. She had SATs of 83%. She had a white count of 30,000, albumin of 1.8. She had an infiltrate on her X-ray, and she had a T2 fracture. So what you documented compared to what actually is happening understates the severity of illness, it understates the risk of mortality, and it understates the resources expected to be utilized to take care of this patient. I wrote here that insurers love this note. Sure they do, right? They're paying as little as possible to take care of one of the sickest patients, right? Just because you didn't write the appropriate things in the chart. So things that we could have done better, we could have assigned this lady a diagnosis of malnutrition, aspiration pneumonia, septic shock. So physicians lose not only the hospital, but the physicians lose because the hospital looks at our length of stay, it looks at our risk of mortality, it has increased costs, and of course there's poor public profiles. Next, please. So what can we do? There's some wording that you can actually use to be a little bit more specific to, and if it's appropriate, have a CC as opposed to no MCCs or CCs, or an MCC as opposed to a CC. So heme positive stool. If you actually have a diagnosis of GI bleed, that's a CC. And if you know where it's coming from, that's even better. That's an MCC. Hypotension, like we touched on earlier, that's essentially nothing. But if you have a diagnosis of shock and then you don't specify, that's a CC. And if you have a diagnosis of shock and you specify cardiogenic, hemorrhagic, neurogenic, etc., that's an MCC. Altered mental status is essentially nothing. Acute delirium is a CC, and encephalopathy is an MCC. Demand ischemia doesn't give you any credit. Unstable angina or acute coronary syndrome gives you a CC, or NSTEMI or acute MI gives you a MCC. A couple of more. Midline shift or mass effect on the brain, not too much credit. Cerebral edema or herniation, that's a full, that's an MCC. That'll change the patient's DRG. Obtunded or unresponsive is no credit, and an MCC would be coma. We take care of a lot of trauma patients, and a lot of trauma patients have head injuries, and I insist that the residents actually write coma, and they're like, well, if the GCS is 6, it's assumed that the patient's in a coma, and that's true, and that would suffice. But just to make it easier for the people who actually go through the charts, I ask them to write coma, so we get credit for taking care of the sick patients. Respiratory insufficiency or distress, as you can see, is no credit. Acute respiratory insufficiency or distress is a CC, or acute respiratory failure is an MCC. And then this one is a little odd. Urosepsis is no credit. Bacteremia or UTI is a CC, and sepsis due to UTI is a MCC. Next, please. Another example. This patient was in my, let's say, we took care of this patient in our hospital, a 72-year-old man who has a history of CHF, who's diagnosed with colon cancer and needs colon out. He has a ejection fraction of 25%. Postoperatively, he has mild pulmonary edema, and it resolves without issue with Lasix. So I write down colon resection for cancer with CHF. Next slide, please. After listening to tonight's talk, you take care of the same exact patient, yet instead of writing colon resection for cancer, CHF, you write colon resection for cancer, acute systolic CHF. Next slide, please. So look at the difference. The patient number 1 is the patient I took care of, and patient number 2 is the patient you took care of. So you can see that they have a different DRG because according to my documentation, it's a major large bowel without an MCC or CC. But in reality, and when you document it appropriately, the patient actually has an MCC, so their DRG changes. So from 331 to 329. The allotted length of stay is also different, 7.6 days versus 12.3 days. And you can see the dramatic difference in the relative weight, 1.62 versus 5.32. And then the reimbursement, 10,000 versus 33,000. Over 3 times as much money is paid to the hospital to take care of DRG 329 as opposed to DRG 331. And my hospital would get $10,000 and your hospital would get $33,000 just because you wrote acute systolic congestive heart failure. Next slide, please. So one other area where documentation is important is mortality. We talked a little bit about it earlier, but essentially they develop a ratio, an observed versus expected ratio, and it's pretty straightforward. What is observed mortality is the number of inpatient deaths, and expected mortality is the number of inpatients who are expected to die based on what's documented. And the ratio is simply the number of observed deaths divided by the number of expected deaths. So let's say your hospital has 100 observed deaths in a month or a year, whatever you want to say. And based on your documentation, you have 100 expected deaths as well. So your observed and expected ratio is 100 over 100, 1.0. My hospital, similar to yours, we have 100 observed deaths, but we're not really good at documenting, so we only have 50 expected deaths. So our ratio is actually 100 over 50, or 2.0. So even though we're similar hospitals taking care of similar patients, because we don't document well, our observed and expected mortality ratio is 2 times yours. So if Mr. Jones needed a cabbage or a sigmoid resection, and he Googles hospitals, and he sees that even though they're similar in terms of size and in terms of reputation, he sees that my hospital has a observed or expected mortality ratio of 2, and yours is 1. Where do you think he's going to go? And to take it one step further, if you actually do a great job and you have protocols and pathways and sepsis teams and stroke teams and MI teams, and you're actually a leader in a certain disease process, you can actually lower it. You can actually have your ODE ratio less than 1. You could have 90 observed mortalities because you do a great job, even though you're expected to have 100. So you'd have 0.9, and Mr. Jones would probably much rather go to that hospital rather than mine or yours. Next slide, please. I think we skipped one. Yeah. So this is just an example of what we just talked about. Same exact patient. Left is my hospital, right is your hospital. 75-year-old from a nursing home with CHF, COPD, AFib, with shortness of breath, pulse ox of 80, and blood pressure of 80 over 40. Same patient. My hospital's on the left. I write shortness of breath, low O2 sats, tachypnea, on BiPAP, ABG's abnormal, sacral wound, and hypotension. But you write acute respiratory failure, acidosis, sacral decubitus ulcer, stage 3, and cardiogenic shock. Look at the difference in mortality, expected mortality rates. Your expected mortality rate, that patient's expected to die 36% of the time, and my patient's only expected to die 1.7% of the time. And if we're taking care of the exact same patients, and I have a 1.7% mortality rate, but my patients are dying at a rate of 36.3%, they're going to shut our hospital down. Because we're not documenting right. That's dramatic, but you can see how it can happen. Next slide, please. So we talked a lot about how hospitals are compensated. We'll talk very, very quickly and briefly about how physicians are compensated, and a little bit about coding. There's a lot of ways that physicians are compensated. You can be private practice and have individual contracts with insurance companies and get paid cash. Employed surgeons usually get paid by RVU, some sort of equation, but RVU is a relative value unit. And what goes into the relative value unit is several things, mostly time and skill. So the time required to do a case, so let's say you get 10.47 RVUs for a lap chole, that 10.47 RVUs includes all of the work prior to and following the procedure, including in the procedure. So when you're standing in the OR, gowned and gloved, and the scrub nurse has to re-scrub because a fly landed on it or whatever reason, all that time is built into the RVU. It's not just the actual OR time. The skill and effort to do the case, the mental effort and judgment, and psychological stress, believe it or not, is built into RVUs. The last two are minor components and not really talked about too much. The main elements are time and skill. Next slide, please. So you would get 10.47 RVUs per lab chole. How do they actually code for it? They use a current procedural terminology, or CPT code you might have heard about. There's CPT codes for everything. I just picked the ones that are pertinent to surgery, which are E&M codes, Evaluation and Management 99201 to 99499, and codes for surgery, as you can see here. So a lab chole has a specific CPT code. So the coder sees that you did a lab chole, sends the code to the insurance company or CMS or whomever, and they pay the hospital based on that code and the DRG, and then the hospital will compensate you based on 10.47 RVUs. Next slide, please. So just quick H&P, there's a lot of information about creating an H&P, but we'll briefly go over it. So I always ask the brand new residents, the interns, within a week of them coming into the hospital, I say, how many of you know how to write an H&P? And they all raise their hands and look at me like I have 10 heads. And then I say, how many bullets does a comprehensive review of system need? And none of them, they look at me like I'm crazy. And nobody knows the answer. So it's almost across the board that none of them actually know how to write an H&P. So there's three elements in addition to a chief complaint: history, physical, and medical decision making. As you can see here, as you get more and more detailed, your level of history is increased from problem focused to comprehensive. Your HPI would be brief, review of systems would be none, past family and social history would be none, all the way to comprehensive, which is a very extended HPI, 10 or more review of system points, and a complete past family and surgical history. As for physical exam, there's actually two sets of rules, 1995 and 1997. I just picked 97 arbitrarily, and it's the same thing from problem focused to comprehensive. So if you have a patient with appendicitis and you push on their abdomen and say, oh, I have right lower quadrant pain, that's a problem focused exam. If you say right lower quadrant pain, rebound guarding, positive bowel sounds, no mass, etc., that would get you to expanded problem focus. And the more and more you do, the higher and higher level you get. Next slide, please. And then medical decision making is just as important. And that implies or that requires number of diagnoses, amount, complexity of data that's examined, risk and complications of morbidity and mortality, and level of complexity. So it goes from essentially minimal or straightforward to extensive or high. So if you get a transfer in and you call the transferring doc and you talk to him about the case, you review all the old records, you look at the CT scans and the chest x-rays and all the blood, that would get you to probably a moderate or an extensive amount of complexity of data. So it's important to document that you're doing all these things because your medical decision making would be higher. So documentation is very important in terms of H&Ps as well. Next slide, please. So how does that affect us? The CPT codes are different for each of these. So if you do a detailed H&P but a straightforward or low medical decision making, you get a CPT code of 99221, which is an initial inpatient hospital care CPT code. And you can see as it goes higher, a comprehensive history and physical and moderate medical decision making is 99222 and then a 99223. And the RVUs are here. You're contracted to get a certain number of dollars per RVU. Let's just say it's 100 or 50. You can see that to go from a 99221 to a 223, you get double the amount of RVUs, you get double the amount of money. So if you're actually doing the high medical decision making and the comprehensive history and physical, if you're actually doing the work, you better start making sure that you document appropriately so you get credit for the work that you're doing. Next slide, please. So Osler said it's much more important to know what sort of patient has a disease than what sort of disease has a patient. And I'd add to that, the chart is the only way insurance companies know how sick the patients are. The insurance companies do not pay you based on how sick your patient is. The insurance companies pay you based on how sick your chart says the patient is. So it's very important to make sure you document appropriately. Next slide, please. Thanks again for coming to listen tonight. Here's my email address. I'm happy to talk to you guys online or in person about any of the questions you have or issues you have, and talk to your divisions or groups or whatever. And I'm happy to take any questions that you have. Great,
thank you so much. So let's get right to the questions. We have one asking, how many times do the MCCs need to be documented? Is once in the admission H&P adequate, or do they need to be in the daily progress note?
The answer is they need to be in the chart somewhere. We ask from our documentation initiatives, we ask that they're either in the H&P or the discharge summary, just so the chart people, the coders, and the document extractors can consistently look at a place and identify the MCCs. Now, they query us. If we don't do that, they query us and say, is this present? And we'll say, yeah, look at page, look at, November 10th, the second page, whatever, and it counts. But just to make it easier, to make sure that nothing is missed, we ask that it's in the H&P, the discharge summary, or a consultation sheet. So those are the three areas that we ask for.
Okay, here's another question. What if a cardiologist notes in her documentation that the patient has acute systolic CHS, but the surgeon's progress note doesn't say that? Is there a difference in payment?
So the hospital is paid based on the patient's DRG. So in theory, the cardiologist note is adequate for documentation. So whatever the surgeon admits the patient for, the MCC of acute myocardial infarction would count towards that.
Okay. Here's one. What's the importance of the allotted LOS?
It's just it's a quality measure to compare from year to year and from hospital to hospital. So if you can average your allotted LOS based on what your DRG is, and let's say your allotted LOS is 5 days, but your actual LOS is 5.5 days, then you know that you have a length of stay problem. And conversely, if your observed LOS is 4.5 days, you know you're doing a great job. So it actually saves the hospital from spending money. So it's not. It has nothing to do with reimbursement, because you don't get paid based on how many days the patient stays in the hospital. It's more of a quality metric.
Okay. Does CMI affect RW?
CMI is RW. It's an average RW, right? So if you take all of the RWs you have in a month, let's say, and you divide it by the number of discharges, and that's your CMI. It's essentially your average RW.
Okay. Does the diagnosis need to be in the assessment? Need to be in the assessment and the plan part, or is it enough to mention it in the medical surgical part of H&P? Hope I read that right.
Yeah, I understand. The answer is it doesn't matter where it is really. We have Epic, so we ask that the diagnoses are all placed in the problem list. Again, just to make it easier for the data extractors to identify where these things are. But if you don't put it in the problem list, but you put it in the plan underneath pulmonary, that is technically adequate. But again, it's likely to be it's more likely to be missed.
Okay, to adequately code for medical decision making, do you need to specify dates of review of labs, CT, etc.? If they're automatically in your H&P, does that suffice? Does specifying reviewing images yourself help?
So everything helps. Everything that you could actually document helps. So I write that I have personally reviewed the films and went and reviewed them with the patient. So just because you write the CT scan result, or Epic auto-populates the CT scan results into the chart, that's not adequate for medical decision making. You have to actually write that you actually reviewed the scans or the results with the patient, etc.
When writing an operative note for a suspected malignancy, pathology pending, Is there a need to amend once the path is back after the patient is discharged?
Is there a need?
Is there a need to amend once the pathology is back after the patient is discharged?
So the CPT code can change based on whether the surgery was for malignancy or a benign disease. There's no need to do it. It would be better if you did it, but we don't do it. And our coders look through, for example, for appendices, they look through all the pathology reports and see if there's a adenocarcinoma in the appendix, and they change it. So there's no need to do it. It probably would be helpful, but certainly not needed.
Okay. What is the importance of mentioning time of care on the note for floor patients, note ICU patients?
So there's two separate issues. For floor patients, so not only, so I didn't get into it because, like I said, we were very superficial, but not only can you change the CPT code and therefore the RVUs based on number of your systems or history or physical or medical decision making, the time of care can also upcode or allow you to get to a higher level of CPT code. So if you write spent 40 minutes with the patient, 50% of which was used to counsel the patient regarding surgical options or alternatives, that will take the place of some of the things that we talked about in terms of medical decision making. Now, for critical care, it's different. In order to create a critical care note, you need two things. You need number one, a critical care diagnosis, and number two, a time. You need to have, you need to document you spent at least 30 minutes in order to bill a critical care note. There's a lot of other issues with critical care notes, and we can go into that if the desire is there. We can certainly talk about that in a future webinar.
Can I use 1995 guidelines for documentation instead of 1997 guidelines? If so, how?
Well, you can use it. It's essentially what you just have to figure out what your institution, if your institution uses one or the other, or most places that I know of anyway allow you to use both, and the coders just need to identify that you're using either. And what we do is we give the residents, when they come into the program, a laminated card with both of them on it, and they probably lose it the next day, but they have both sets of guidelines on it, and so you can see what you need to get to or based on what you've done, what CPT level you're at. Okay, and I think that wraps up our questions for this evening. Thank you so much. I've seen others that have weighed in and asked for this to be a series. So clearly we've got a lot of people interested in this topic, and judging by the number of questions, it's not an easy topic to digest, certainly not in one 60-minute setting. So thank you again, Dr. Lieberman. I wanted to invite everyone on the call to our next webinar, which is going to be held on Tuesday, November 15th at 7 p.m. Central Time. And this subject is on the basics of fundraising, titled Hope is Not a Strategy. Shane Hollett, the Executive Director of the ACS Foundations team, will be leading this discussion. So we invite you to sign up, even if you're not able to attend the live session. If you do register for any of our webinars and do not attend, you will be sent a copy of the webinar afterwards. Webinars are also housed on the ACS website under the Resident and Associate Society homepage. So please do look at the selection. We've probably had 8 to 10 already this year, and we're looking forward to more in the next 12 months. So thank you again for your time and attention this evening. And until next time, have a good evening. Thank you.
Thank you.